And in thinking about things like clinical trials and research, but also kind of the patient population as a whole that might be participating in this, I'm so curious, has the population of MASH patients changed at all over the years? You know, we hear about changes in different fields, even oncology, for instance. Younger people are getting different types of cancers that we're not used to seeing. So I'm wondering if any of those types of changes have cropped up in your field.
Yeah, so with the epidemic of obesity and type 2 diabetes, again, some of the most common risk factors for MASLD, the patients are seemingly getting younger and younger, and it becomes all the more important to act early for them as well, especially when they come through and our initial screening shows at risk fibrosis. Though you have to act really aggressively to modify the course for the clinical course and life course for these really young patients.
Hmm, interesting. And do the patients skew any particular category? Are there more females or males, or is there maybe a certain ethnicity that you see most often?
So, touching on the at risk and ethnicity piece, so there are certain populations that carry, for example, a genetic risk factors. The one that we study and test for here called PNPLA3, which if you are a carrier of one or two of the alleles, you basically have a moderate to higher risk of basically developing fatty liver disease. So when we do this test and we find it positive in patients, whether it's one or two copies, there's nothing to do about the presence of the gene. It just makes it that much more important to be aggressive in diet, lifestyle, and medically manage cardiometabolic risk factors to basically halt that risk and minimize it as much as possible.
Mm. You know, there's this new like $4,000 test at Northwestern where they basically test you for everything under the sun. I'm wondering, when you mentioned having these genes and the alleles, what opportunity are patients having to identify that they have those genes, or these kind of incidental findings? Like, when would a patient come across a test like that preemptively, say, so that they know that they need to keep an eye on their liver?
Yeah, within our clinic, it's part of a routine. Every new patient who comes through gets this evaluation. It's more common, for example, in the central and American population. For example, like those of Hispanic descent. So, especially if you already come into clinic and have comorbidities, you have struggling with obesity, you're diabetic, and now you have a genetic predisposition that's going to basically make you increase your risk for MASLD. That's a very important conversation to have because it's something you basically carry with you. It's not a non-modifiable risk factor for which you can only modify what you can control, which is your weight, diabetes, and all the other risk factors you carry from a metabolic perspective.